also the biotech for the opportunity. Friends, what I'm going to talk to you about is one of my favorite refractive procedures, which is the phakic lens. And now the main thing is going to be what are my expectations from the ideal phakic lens implant, and if there is anyone that comes close to that. Friends, we all know that the refractive surgery of today has gone through almost a century of innovations. The first refractive surgery which was ever reported was actually a posterior RK by Professor Sato, and that was done in Japan. So from almost 1920s to now 2024, we have come with a long and a very, very dynamic journey of a lot of new innovations. And these innovations have gone parallelly. There have been innovations which were happening on the corneal laser refractive surgery front, and parallelly there were innovations which were happening on the lens-based procedures, which involves your phakic lenses and also the refractive lens exchange implants. But as of today, the thing that we are come to is in the form of Contura, Smile, advanced surface ablation, and the phakic lenses are currently the top choices for our patients. But when it comes to refractive surgery generally, the first global phenomenon which actually made refractive surgery a household name and extremely popular was the LASIK surgery. LASIK was first done by my mentor, Professor Ioannis Palikaris, in 1989, and the video that you're looking at is the first ever LASIK done in the world. So this was done in Greece, and with a lot of advantages of LASIK in those times, like very, very quick recovery, a good amount of predictability for high differences in terms of myopic corrections, hyperopic correction, astigmatic corrections, no haze and very less regression. This scored over the previous technique which was called as PRK. So in the beginning, when the LASIK was started around the world, actually there was no limit. People used to go and they used to ablate corneas for very, very high diopters. Although LASIK was approved for almost minus 12 diopters, people have gone on to treat 12, 13, 15, 18 diopters over time. And slowly when these patients came back for follow-up, it was seen that higher the intended correction, the thinner the cornea became, the flatter the cornea became post-operatively, and that lead to a lot of optical phenomena because of oblate cornea. These optical phenomena was loss of quality of vision, induced spherical aberrations, induced coma that led to a lot of halos and glare in the night. Of course, chances of ectasia went up and regression was seen very, very commonly. So currently, slowly, the trend changed back to get our corneal refractive surgeries up to -8 or at max -10 diopters with the current generation procedures such as femtolasic, Smile or Contura. And for the rest, this phakic lens implant, that is what we are going to talk to you about, have actually replaced the previous generation surgeries. So as of today, a refractive surgeon has to be well versed with not only LASIK, which is a corneal refractive surgery, but also know the nuances of phakic lenses. And the phakic lenses are nothing but artificial lens implants which are done either in the anterior or the posterior chamber of the eye in presence of the natural crystalline lens to correct refractive error. And just to give you a small glimpse of the things that we discussed, this was a nice report that we had published back in 2007. Our group had shown that in one eye, if you do LASIK in this particular patient who had -9.5 diopters of spherical equivalent, and in the other eye, the patient underwent a phakic lens implant, and over 10 years, it was seen the eye which had undergone LASIK had regressed to -1.75, and the other eye, which was the phakic lens implant, was still very, very stable with only 0.5 with a great quality of vision. So as of today, if you have -8 or -10 diopters or beyond refractive error, or in case the cornea is not up to the mark because of thin cornea, keratoconus or dry eye, and if your the internal chamber depth is 2.8 or beyond, definitely the phakic lens implants are the choice. The phakic lens implant in itself has gone through a lot of generational changes, but the one that we have zeroed down on is the location in the posterior chamber. And the first ever posterior chamber implant was done by Professor Fedorov in Russia. We know that there are a lot of phakic lens implants which are there, and the first one which actually became USFDA approved was the STAR, but now this new implant, which is the ICRIL lens, which has been around there for almost 8 to 10 years, has been an excellent choice and is approved also in the European region. So currently, as we have seen, the phakic lens implants have to be used in particular zone and scenario. But the beauty of phakic lens implant is that you can treat very, very wide array of refractive errors with a lot of great advantages over corneal lasers. So this phakic lens implant, which is the IOL phakic lens, we have fortunately had a very, very good experience with this. We were one of the first centers in India to start implanting them when it was introduced as a trial site back in 2014 and 15. And we have so far done a good number of these lenses. So when it comes to what do I expect from an ideal phakic lens, of course, what I want from my colleagues, for our surgeons who would like to start phakic lens implant, I definitely want that this phakic lens implant should be very easy for them to calculate. There should be very easy to use kind of scenario in terms of handling, loading and insertion of these phakic lens implants. We also want that the backup support from the company has to be excellent. The toric phakic lens implant should have a good amount of stability for rotation, and a higher refractive error customization should be possible even beyond what is naturally available with the other companies. And of course, there has to be a constant training and support which should be given to the new surgeons. We all know that when it comes to phakic lens implant, your first win is when you actually have the right power and the right size of the phakic lens implant. And when it comes to that, they have an excellent calculation tool which is available online, where you have to feed all the data that you have. And with all these things together, it will actually not only give you the lens which is going to be suggested, it will also let you know what is the residual astigmatism or residual refractive error which remains, so that you can choose the closest lens to your requirement. And it will also show you if this lens is in their inventory or not. I think this is currently the only company that gives you this online, where you can actually know beforehand if the lens is readily available or it is not. And that gives you a lot of leeway when it comes to talking to your patients, especially counseling them. There are different parameters, of course, that we have to put in. As you know, the keratometry, K1, K2, the spherical refractive error, your cylindrical correction along with the axis, your corneal thickness, pachymetry, backward distance, which is standardly taken at 12 millimeters, your white to white, which should be ideally taken by 3 different instruments, and the endothelial, or what is called as the internal anterior chamber depth. Now let us look at what is the advantage of this particular lens when it comes to handling. Now this is the other lens that we have some experience with. But if you see, these lenses, at least in the beginning, surgeons are slightly more difficult for them to maneuver or to load, because it requires a bimanual approach. It requires front loading. You cannot touch these lenses with any kind of forceps. So this is what is called as the bimanual or the front loading approach. You can see this lens is actually put in this cartridge, and you have to use a very, very specialized forceps to drag it. And sometimes if you are not very, very careful, you can tear the lens because they are very, very fragile. As against that, if you see the acryl phakic lens, if you are somebody who has been doing cataract surgery routinely, you will just see that the loading is seamless. It is extremely easy because the loading is exactly similar to your plate haptic cataract IOL. It is very, very easy. You just have to tuck it in. You can definitely, these lenses are stiffer, so you can actually handle them with forceps. You have to make sure that the flanges go under the side margins of this cartridge. It is very, very easy to load, and also this assembly is created very, very gently. If you were there for the live surgery yesterday, you must have seen in the live surgery how easy it was for me to load this lens. Now this is the implantation. You can see the lens goes extremely in controlled fashion, does not open in an erratic fashion. It has never ever opened upside down or in tilted fashion. So extremely predictable when it comes to its implant as well. So when it comes to the other support, you will be very happy to know that you get a backup lens. So if you actually are a beginning surgeon and you are going to make any mistakes in loading or in implantation, there will be another lens which will be given to you, and you can use that as the backup. That will give you a peace of mind. And one other beautiful thing that I have seen is that here you don't have to rotate the lens for more than 15 degrees, and that's the reason that actually the stability of your rotational instability of these lenses is lower and the stability is better. So if you have seen, some of the studies have actually looked at, as you go from horizontal to vertical, your sulcus to sulcus becomes wider. And that's when you go beyond 15 degrees, you will see that there is going to be a gap which is going to be created between your foot plate and the end, between your foot plate and the sulcus, and that is what causes the rotational instability for these lenses. So instead of having a 4-point contact, the lenses which require 22 degrees tilt will be more unstable. But the beauty of the Biotech acryl lens is that the tilt is only up to 15 degrees rotation, and that's the reason that this gives a very, very snuggle stability. These lenses also have other advantages because you can completely customize them. You can go even beyond minus 18 diopters, which is available in the other, let's say, option that is available in the industry. It gives an excellent quality of vision in the night because your effective optical zone at the level of the pupil is always beyond 6.5 millimeters, and it is hardly known to give any amount of intractable or severe halos or glare phenomenon. So what we have seen so far is that these lenses are beautiful lenses when it comes to handling them. The support that you have for the calculations is very transparent, and it is readily available. You have ease in handling, in loading, in insertion, and also tucking. You don't have to rotate these lenses more than 15 degrees, though the stability is much better. And most importantly, they go through a very tiny incision of 2.8 millimeters, and they are completely customizable even for any high emmetropia that you can deal with, which is the definite very big advantage. Now, one more unique thing about this lens is that when you go to hyperopic treatment, most of the other manufacturers do not have the central hole, and this central hole is required for you to avoid the peripheral iridectomy for these patients, and also to get rid of your viscoelastic which is behind the lens during the procedure. And this is something which is unique because in the IOL hyperopic lenses you still have the central hole, and that definitely gives you that big advantage. Also, they give you a good amount of complication management support because they have a lot of surgeons who are on their board, and they can help their peers to go through any complication management, a vault issue, sizing issue. You always have somebody with you. This is a very nice article which was published in JCRS, who have looked at 5 years data of this acryl phakic lens, which is now CE approved. They have shown that this is a very good option, a very effective and safe refractive surgical procedures over 5 years of duration of time, which is a reasonably long-term follow-up. This is another very unique and nice, interesting case where they have actually compared the acryl phakic lens with the VG and ICL, and what they have seen is that the outcomes when it comes to the visual outcome of uncorrected visual acuity, best corrected visual acuity, the spherical equivalent, and the residual astigmatism was exactly similar over duration of 2 years. But the most important thing is what is called as the dynamic vault. Dynamic vault means that whenever your photopic and the mesopic phenomenons are coming in, when you have a light intensity which goes up and down, the pupil, sometimes the iris tissue presses onto these lenses and can cause dynamic change in the vault, and this dynamic change was seen to be much lesser with the acryl phakic lens, only 65 microns as compared to the other one which was 121 microns. So definitely a great, absolutely very close to the ideal option of phakic lens is what I will say. So currently, if you have a patient who has a stable refraction, who is probably a LASIK reject of myopia beyond -8 diopters, is hyperopic more than +6 diopters, and has still a good anterior chamber depth, has initial corneal thickness less than 480 microns, a residual bed after LASIK less than 280 micron, either a very flat or very steep cornea with significant dry eye, or patient who is already keratoconus suspect, or patients who have had keratoconus but now are stable either naturally or with post CXL. All these patients are absolutely a great options for your phakic lens implant. And these acryl phakic lenses have a lot of advantage, as we have discussed, and all these come into play with some certain unique features that they offer to you compared to the other manufacturers. So we have been extremely happy with these lenses so far, with almost a decade old experience, and I'm sure that we are going to hear more about this with Dr. Kudlu also. And I would like to thank Dr. Namrata and the entire AIOS team, and also LOC in Dehradun for fantastic arrangements and the kind invite. Thank you very much. Thank you.
Thank you, Dr. Vardhaman. It was really, you have covered the topic very well. It was a very nice presentation. And in continuation, we will have another talk. There are 2 talks on phakic IOL, so we can have a talk by Dr. KP Kudlu. And meanwhile, if there are any questions for Dr. Vardhaman.
Vardhaman, if to start with the phakic practice, what do you think that which are the basic machine in the practice which are needed?
Right. So the good thing about the phakic lens practice is that you really don't need extremely high-end machineries. There are 2 things which are most important when it comes to that. Number 1 is, of course, your refraction has to be very good. Number 2 is when it comes to the sizing, you should have if you have access to a good tomographer, which is either the Cirrus or the Pentacam, will definitely give you a good advantage. Along with the current generation biometers, which are optical biometers like IOL Master, they can give you a good white to white. But the most important thing that we rely on is the digital caliper. So even if you don't have access to the tomographer or the optical biometry, still you can have equally good outcomes if you have a good white to white sizing machinery in the form of a very simple 2000 rupees tool, which is the digital caliper. So with such simple tools, you can actually have a very, very good outcome.